Welcome, everybody. Thank you for joining us this evening. I know everyone's schedule is a little bit busy, um, but welcome to our VIR match series, our surgical intern year panel. We have some amazing panelists with us here today, and we are going to be excited to introduce them here. But before that, we're going to introduce a little bit about our society so that you're in the know. A lot of you already are. Um, and on top of that, we're going to make sure that this is recorded so that if you want to recommend this video to anybody else who wasn't able to make it here today, you're more than welcome to do so. But in the meantime, I'm going to hand it over to Danusha, and he is going to discuss our organization a little bit.
Hi. Thanks, Ryan. Yeah, as you mentioned before, I introduced the panel, just want to talk about WCVIS briefly. So our mission statement is to develop a trainee section to educate, recruit, and connect those passionate about pursuing a 100% endovascular interventional surgical career with comprehensive and longitudinal clinical care. The direction of VIR as a specialty will be defined by those who will not compromise in providing the best possible care to their patients. We have structured our trainee section to support individuals at every stage, including pre-medical, medical student, resident, and early career. I'd like to take this time to talk about some of the several ongoing projects that we have that are aimed at helping trainees to learn, prepare for, and succeed in VIR. Some of those projects are listed here on the slide, and they include a spreadsheet for all VIR programs with information including VIR months, PGY 2 through 4, amount of clinic, vascular experience, neurointerventional training, etc. Many of our projects are packaged into series, such as How to Crush Your Sub-I series, the Acute Care series, WCVIS Match series, Unite plus WCVIS series, and the Landmark Trial series. We have educational projects as well, such as procedure guides for Spanish-speaking patients, and mentorship projects too, like Mentor Match and the Resident Office Hours. Lastly, we have an upcoming podcast on 100% VIR practice, and please stay tuned for many more projects to come. Now, I want to talk about a few of our upcoming events that we have. The Transnational Vascular and Interventional Radiology Journal Club is hosting a discussion on the management of ruptured abdominal aortic aneurysm, AJAX, IMPROVE, and ECAR. This discussion will take place Monday, December 8th, 5 p.m. Pacific Standard, 8 p.m. Eastern Standard Time, and the relevant trials are linked here on the slide. Next, we have Surgery Through a Pinhole, an introduction to VIR for pre-medical students. This will take place on Thursday, December 18th, 7 p.m. Pacific Standard, 10 p.m. Eastern Standard Time. And this is a great talk for our pre-medical students. It's a chance to discover vascular and interventional radiology, one of the most innovative and diverse specialties in medicine today. Imagine performing a life-saving procedure through a tiny pinhole, from treating cancer to stopping deadly bleeds. Our pre-med event discusses how vascular and interventional radiologists are using cutting-edge technology to provide alternatives to invasive open surgeries today. Join our experts from Kaiser Sunset in LA and UC Davis Health to explore this future-facing procedure-driven specialty. If you're at all interested in joining the WCVIS trainee section, please sign up at the link below here, or you could scan the QR code at the bottom right of the image. Sorry. Okay. Thank you. You can, if you want to stay updated on our events and organization, please follow us on social media at WCVI Society on X/Twitter, Instagram, TikTok, and YouTube. And you can add our Google Calendar to stay up to date on upcoming events as well. You can find the link to that. It's on our website under the events tab. And lastly, please check out our website at wcvis.org. All right, with that, I'd like to begin introducing our esteemed panelists for tonight's event. First, I'd like to introduce Dr. Tulasi Talori. She's a current PGY1 and completed her medical school at Oakland University William Beaumont School of Medicine. She's currently doing her surgery year at Kaiser Permanente Surgery, Los Angeles Medical Center, and will complete her VIR residency at the University of Southern California Keck School of Medicine. Next, we have Dr. Deshaun Abedira. He's a PGY2. He completed his medical school at A.T. Still University, his surgical intern year at Kaiser Permanente Surgery, Los Angeles Medical Center, and will complete his VIR residency at Kaiser Permanente Vascular Interventional Service, Los Angeles. Next, we have Dr. Jonas Cruz, PGY3. Dr. Cruz completed his medical school at Ann Burnett Marion School of Medicine at TCU, his surgical intern year at UCLA, and will complete his VIR residency at UCLA as well. And last but not least, we have Dr. Ahmad Farag, better known as the Final Boss. He completed his medical school at the University of Louisville, his surgical intern year at University of South Carolina at Greenville, radiology residency at the University of Kentucky, and his VIR residency at Baylor University Medical Center. Dr. Farag is currently the Chief Medical Officer of the Advanced Vascular Institute in Panama City, Florida.
Amazing. Okay, thank you, Danusha, for going through and introducing everybody, and a special thank you to our panelists again for taking the time to be here. Make sure that everybody's spotlighted front and center. I think I just kind of want to start this conversation off because there are different options depending on the program that you're applying to in terms of integrated VIR, in terms of what you can sort of choose as your intern year. And so I wanted to sort of see what everyone's thought process was with that, or if your program, for example, had a required year and required you to do surgical intern year, or if you really had to make the decision yourself. Um, who wants to start with that?
I can kick us off. So, everybody, third year at UCLA, our surgery year is built in. So anybody who goes to UCLA is going to do your surgery year here at UCLA. I think for Deshaun, it's the same. Um, though that being said, I think last I checked, it's about a third of programs that are built in like that. A third, it's recommended / required, and then a third you can do whatever kind of intern year you want. For me, I only applied for surgery intern years. I think there's utility in, in internal medicine, a transitional year or a surgery year, but I think those are your three primary options. And out of those, I think it's pretty clear that you're going to get the most out of your surgery. It aligns closely with what you're intending to do in the future. And so what I was looking for, what it came down to was how much time am I going to get to spend taking care of similar pathology that I'm going to be dealing with throughout the rest of my training. How closely does that align with the other information when it comes to, let's say, post-surgical anatomy, things like that, that I'm going to have to be more and more comfortable with. Technical skills helpful, how much time we're spending in clinic. And then kind of an aside, I always recommend, if possible, consider doing your intern year if you do have the option at the same place that you're doing your training. Not just for ease of moving and stuff like that, but getting to know the other departments at your hospital, getting to know how they operate, who the main people are, and then building those relationships with other services that'll serve as you continue your training there. I think all of that's just a really big benefit.
Very well said. Does anyone have anything else that they want to add, their perspective?
So I always say I kind of lucked into where I went. The Almighty smiles on you sometimes, and you just kind of luck into something great. So the I guess we all have the option TY surgery or IM, or I guess OBGYN in some cases. But if you talk to any IR attending or you talk to these program directors and you kind of ask them like, hey, how am I going to get really entrenched in and really prepared for it? And the advice I got was over and over and over, do a general surgery prelim, do a general surgery prelim. And it's kind of a daunting task because, as a fourth year medical student, you tell yourself like, hey, what do I want to do? And everyone knows that, a surgery year is going to be really tough. But ultimately, if you can kind of tailor it. There's so many general surgery programs out there that you can find a program that has a great culture, lets you get in the OR, lets you get your IR time, and kind of kind of builds you. That first year is so important to building you in terms of toughness, knowing what's going on, knowing how to handle the floor, knowing how to handle consults while you're also getting in the OR and things like that. It's super important that that just really gets ingrained. In my opinion, these surgical prelim years, especially the good ones, the separate the soft ones from the non. And I really lucked out in having one that it was tough. I'm not gonna lie, it was a very tough year, but everyone around was so pleasant, and it was a very, cohesive, team-like environment that even though we got in sometimes 4 or 5 a.m., it didn't leave till 7. It didn't feel like that. And the truth is, that's really how IR is. IR is sometimes very difficult, sometimes militant, and just getting that ingrained from year one is just super important. So I was very blessed and thankful that I ended up at where I ended up for my intern year, and I really really recommend that everyone kind of follow a similar pattern. You have the option. You can there's lists out there that tell you places that give you all the best of everything. You're gonna have to work. It's not gonna be the most fun, but what you get out of that year to this day, I still use those in my OBL.
Yeah, I would agree with both of everything what you both said, and yeah, I think getting in on the ground floor, especially like Dr. Farag was saying, is crucially important because when you're, especially your intern year, I feel like it's when you kind of start shaping how you think about things. Even when you get like a consult or something, the surgeon's approach to thinking about something is I think pretty different compared to hospitalist. And in VIR, we kind of have to have that similar kind of approach, when to operate, when or not to operate, being efficient, and including all the other points that were said. I think just learning how to think and getting that ingrained early is really key, and then it helps you kind of build on top of it as well. So I would just wanted to add that.
Yeah, thank you. And all these things like really do make sense to me, and it sort of really does align with our field. And Dr. Frog was mentioning that you have to look for a good year, like a good surgical intern year. So I wanted to ask what your opinions are on that. Like, what is a good surgical intern year for a future VIR resident? Like, what are some of the things that we should be looking for, some of the skills that overall we should be taking away from this year?
So, in my opinion, it's a place that lets you do it all. Most of the places you go to, and this is medicine, TY, whatever you're going to do in scut work. So, and while there's, to some degree not getting around that, you want to go to a place that lets you get into the OR. I mean, I left that intern year with, I think, like 200 plus cases. And it wasn't easy because you're the intern, you're holding the pages. So you do a procedure and you're hauling ass, running back onto the floor to, catch up with all the consults. But I think that really separated it because when it was all said and done, I knew most of the procedures going in. I wasn't able to do them by myself, but sure, tips, lines, drains, whatever. I saw them all and I got to participate in them. So, and then the management of them, on the floor when you're pulling out those tubes or handling those tubes or dealing with a patient that has 15 tubes in them, you don't get those skills overnight. And, that can be kind of intimidating your first time looking at it, like, oh, what am I doing here? So I would say a place that really lets you get in the OR, that gives you that. They gave me like 2 months of elective time, and this is something I asked for even before the year started. I asked for thoracic surgery, I asked for vascular surgery, I asked for ICU, and they told me like you're the first intern that's ever asked for these. So you can really tailor it. So a place that lets you tailor that, and also like I'm gonna harp on this. A place where the culture is good. They treated me like another intern. They didn't treat me like a prelim. So going in there, I didn't feel different. If anything, I felt like we were on the same, equal footing. And it really made it to where I could really get, entrenched in what I was doing. So definitely number of cases, balance of floor work to OR, and just overall experience. You don't have to have a terrible time. It can be a really, really pleasant experience. So, and you can ask them, send a program director point blank, like, hey, how much ICU vascular surgery, do I get IR elective months? Am I able to customize my schedule? And then how many cases on average? And if they can't answer that question, then consider not going there. But there's a lot of programs that will be able to give you that, and they can guarantee you if you ask early enough.
I'd also add, love the critical care comment that I think when it comes to management, something maybe a lot of people take for granted is your intern year is going to be the bulk of your inpatient management of patients for the remainder of your training until you come back to, depending on your program, set up additional ICU months in between. But otherwise, if you just do baseline ACGME, that's PGY 5 year. And so getting really comfortable with sick patients, or as comfortable as you can during your intern year, I think is helpful. A lot of people will talk about operating time. I think there's a lot of benefit to being in the OR when it comes to your hand skills, understanding different anatomy. Another thing you can ask is the variety of what kind of cases you're doing. I think there is a ceiling to, your takeaway, depending on, if you're doing 50 to 100 breast cases. By, towards the end of that, you're not really taking away as much. So just thinking about, okay, what kind of cases am I scrubbing into? And then, yeah, your clinic time. You're dealing with a lot of pathology that you're going to see as a VIR. So something to consider is what kind of patients, what kind of clinic you're going to. And yeah, staying busy. So I think when you are dealing with your surgery intern year, you want to kind of get your butt kicked. You want to get the reps that pays dividends down the road. Most surgery years are going to be pretty busy. I think the reason you're busy is what's important. So if you're busy because you have a census of sick patients and you're dealing with complexity and you're dealing with, things that are going to be kind of burned into your brain in terms of how you manage certain patients, it's a good kind of busy versus like a cultural busy where people are just making your life harder because you're the intern. I would say that, it's easy to kind of lean on, obviously the first being the better option. But yeah, when it comes to kind of culture of a program, usually if you're at the same institution you're doing training, talking to my friends at other programs, people kind of know that the IR residents have their own institution there. They usually are treated like one of the other surgery interns rather than a quote prelim. And so that's always kind of fun.
Yeah, I agree as well with all the points that were said. Yeah, and Kaiser specifically, they expect us to all of our matches have to go through the surgery engineer here. So we're treated just the same as the surgery categoricals, and I think it was great. Like Dr. Farag said, I think I ended up clocking around like 250 cases, something like that. So every day, you round, and then once you finish up your notes, you're in the OR, and you're expected to be in the OR. If you're not, they're even going to say like, oh, where's Deshaun? Like, why is he not in the OR? It's like that's the kind of place that you want. You want to really get in and treat it like as if you were a categorical surgery intern and like get as much as you can out of it. And then to Jonas's point, which I really liked, also getting involved in the clinic. The surgery clinic in many ways is very similar to how VIR clinic is going to be as well. Like seeing consults, seeing whether you should operate or not, interfacing. Even all of our clinic spaces are next to each other. And even now, when I do clinic with Dr. Vatican Cherry, we talk to the surgeons all the time. They're a couple of doors down. So getting all of that stuff early, and then, you know, I think another piece of advice is talk to some of the prelims who have been there in the past, or even, I feel like if you were even just reach out to the residents and ask them like, hey, like, how much OR time did you get? How much clinic time did you get? What were the variety of cases? I think most people are pretty candid about being honest about it, I think. So even just reaching out, especially prelims who are no longer there, I'm pretty sure they'd tell it to you straight. So just another good point of advice.
I love this. I had such a good time that, when they have like the surgery dinners and the recruitment, all that, I was the recruitment chair as the prelim. So it really spoke well about the program when, a prelim was recruiting the other surgery guys in to let them know about the program. But yeah, I love that. And, I also want to point out, I didn't do my surgery prelim at the same institution. And I do agree with all the things you said earlier, Jonas, that, makes life easier, everybody. But I also think that, knowing the ins and outs of how to do everything and be spectacular at everything, and that communication is very important. And, in your career, there's going to be several times, especially go to a new place, new fellowship, start a new job, get that number out to everybody. That's the first thing. When I met somebody new, I got their phone number, I had it saved, I let them know, and you get so much more done by just being able to text and say, hey man, what's going on? Oh yeah. Instead of waiting through a console on the computer to take like 45 minutes by the time you figure out what's going on, just shoot, hey, what's going on with this patient? Let's talk about it. So I think it's very important, that communication that you all talked about earlier.
Those are all really great points, and I agree with Dr. Frog. That is a huge green flag if you're if a surgery prelim is representing the program. So it sounds like during this year a lot of time where you are the primary clinician in terms of managing admissions, writing orders, seeing consults, doing a lot of different things. How has this impacted the way that you view VIR holds a responsibility to the patient beyond the procedure?
I can say just from my practice as an attending, I don't view anyone else as primary. Like every patient that I touch in the OBL, everything I bring to the hospital, when I cover hospital days, I treat every patient as if I'm the primary on there. I'm the decision maker. You know, you really got to look at it. Like a lot of people treat it like I just do consults and I get out of there. You really got to take these patients as yours and know them from A to Z. And especially if you guys want to get in the outpatient setting, you are essentially their primary when it comes to everything. You're working everything up. You're making the decision. You are the final boss when it comes to everything that happens with these procedures. So I think taking ownership of everybody from A to Z is very important. I know everything about every patient that comes in there. And a lot of times, even though it's not, VIR related, we're at least putting them in the right direction and kind of acting as that quarterback and everything. So I really think that, the IR as a landscape is shifting towards that. We're no longer just, the hero hotline where you call and we do some magic, we're everything from A to Z. So I think that's really shifting towards that.
Yeah, I think it was super beneficial to learn that here at Kaiser. We actually earlier this year became our own department, and we have admitting privileges as well. So, just as an example, one of the clinic patients I was following with Dr. Vatican Cherry, we were doing wound care. We found out that we were pretty sure he had an infection. He needed to get admitted. He needed to get IV antibiotics on board, some debridement. So we just straight up just admitted him from clinic the same way surgery does. And so having that experience first year, I think is super helpful. And then just to echo what Dr. Farag was saying, you're going to run a clinical practice, which is the future of VIR. Having those skills set early and then just building on it over your years, I think would be super helpful.
Yeah, I don't have much to add on top of that. It's all really good points. I would just say when you may be the consulting physician, depending on what the case is and how long you've known the patient, but having that mentality, if somebody calls you, you're going to go see the patient. That's surgery 101. Doesn't matter if you on the phone immediately think odds I do anything are super low. Surgery 101, I'm going to be bedside. I'm going to see the patient. This is my responsibility. I'm going to make the decision. You're not going to tell somebody, hey, just make sure they don't have phlegmasia and we'll take a look tomorrow. You're going to go assess that patient yourself. You're not going to take for granted that somebody else has done a thorough clinical exam. All of that is your responsibility, and that comes surgery every single day. So I think it's one of the biggest things that I take with me day to day moving now.
One last thing on this subject. I think uh just one tool that I recommend everybody does, every patient you touch, even regardless of the situation, if you have time, go try to say hi to them. You did the liver biopsy, go say hi to them afterwards. You did a tips, you did whatever, obviously the big cases you're going to do it, but even small things like lines or whatever while they're in, post-op, depending on how you all are set up, just say hi. The nurses love it. It makes you look great and you catch all the problems right away. One of your residents did like a low biopsy on something and suddenly there's a pneumo, you're going to catch it before there's even a problem. I'm telling you that, especially when you're rounding too. Um, if I had nothing else to do and that's rare, I would just go round. Just 10 minutes, go see everyone, say hi. You'll catch just about every problem before it becomes anything.
I love these points. And a little bit ago, we were discussing different types of rotations, requesting certain rotations during the year. And we talked a lot about like ICU rotations. On top of that, are there any other rotations during your surgical intern year that you think have been especially beneficial for you moving forward? Either, that you think that you'll stay and benefit from long term in your career, or maybe even just the first few years of your residency training?
I would say everybody says vascular surgery, urology, any kind of GI surgery. I think colorectal, anything like that is going to be helpful. Something particular for us, I think we deal with a lot of transplant patients, and we have a liver ICU. That's known as like one of the gauntlet rotations. When you're an intern, your ICU is like 40 patients. You're floor census is another 30 or 40, and then your consults, your ED, all of that. Overnight, I think you get very comfortable dealing with very, very sick patients. They're sick in every way, but they're also something that we deal with from, you know, from a procedural standpoint and from a management standpoint. And those are patients that get very sick very quickly. And so just having a ton of reps has been, I think it benefits everybody in our training program. Other things are, I think some people try to look for maybe some rotations that they've heard are more chill. I think, going into endocrine surgery or plastic surgery, unless you're using that extra time to do something that benefits you, I think those are rotations that if you can potentially help, your schedule by avoiding that and doing something that might be a little more high yield for you. But we get a couple months of vascular surgery, we get a month of IR, we get our liver ICU, and then all your core GI, thoracic, neurosurgery, things like that. I think those have been beneficial for us.
Yeah, I think everything you just said is pretty much money. I really thought so. My vascular surgery rotation was the toughest in terms of a lot of cases. We were expected to scrub into everything. We had, 40 consults a day. So I distinctly remember that rotation as, one of those like you had to level up on it. On top of that, that's also where we got, the foundation of my skills. And I kind of got lucky that I did vascular surgery right before my first IR elective. So I got to take everything I learned there and then go into IR and go have fun. So, by the end of that, you're able to put in ports by yourself. You're able to put in lines by yourself. And yeah, that might not be the most spectacular thing, but as an intern, it is. So, I would also say thoracic surgery for me was really big, just knowing tube management, how everything goes in surgical oncology. If there's ever a rotation where you're going to have a patient with 15 tubes, it's surgical oncology and just learning how to manage everything and getting in the OR and getting to see some really tough cases. I mean, that's really going to be one of those times you see, all those huge Whipple crazy cases like that you get in, scrub in and just get some technical skills in the process. They're not always the most fun and they're long, but I really enjoyed those rotations.
Yeah, I'd agree with what everyone has said. And for Kaiser, I think probably the highest yield ones for me were vascular surgery, surgical oncology, like Dr. Farag said, was a big one for me too. And then also just ICU. So not too much to add. The only thing I'd say is for vascular, it's super fun getting into, open AAA repairs, like even fistula creations and all that stuff. But on the floor, when you're rounding with your attendings, pick their brain about, what they think about this like vascular Doppler or wound care and all these things. I think that was one thing that like, you think of, but is huge when you're trying to do clinical practice later on, kind of learning how to do wound care, learning like, oh, like, what do you think of the color of this? What do you think of this Doppler signal? What do you think of this ultrasound? What do you think of this velocity? So just picking their brain on that stuff too when you're rounding, I think was super helpful.
Yeah, thank you. And we were talking a little bit, and Dr. Frog mentioned that he had some IR elective during that time. How much built-in VAR time do you have on these surgical intern years? Is there any effort to sort of incorporate that into the year, or does your program, or maybe if you've heard of other programs, just sort of say, "We'll see you in a year. Just go about your training and just kind of be hands off with it."
So every program is going to be different. Some are built like mine was built in. At least 1 month was built in, and I was able to get 1 month added on. It actually worked out to where one of my co-residents had a month that he wanted to do on my schedule, and that month was a month that I could switch to do something elective. So you may have to get creative with it, and the earlier you get to it, the more they're going to, because when the chief makes the schedule, the last thing he wants to go to is rearrange it. That's incredibly difficult. But if you, get to it right away, and some of them are cookie cutter, so you kind of get what you get. But you can always go and ask, like, hey, during this time, can we switch this around? And as long as you make it to where you're doing the, some of the work to make it not as painful for whoever has to change the schedule, they usually can work with you to some degree if you get to it early enough.
Yeah, Kaiser, we had 1 month built in as the categorical, but all of the prelims who are also going into VR just match somewhere else, they all get a month as well. That's pretty much a built-in standard for our engineer.
Us too. Kind of back to a plug for just having one of the benefits to having your own program at the place you're doing your intern year is you are not just a prelim, you have the backing of an entire department. You have your program director and your leadership that can go to bat for you for something like that. When I started as an intern, our schedule didn't have it explicitly on the schedule, but we had these kind of elective slash flex blocks, and we asked, and then our leadership kind of brought it up. Our program director, our section chief brought it up to them, and we were able to integrate that. And now moving forward, we get a month every intern year.
And I don't think anyone mentioned this, and I know every institution is going to be a little bit different in regards to trauma exposure during the first year, but I just wanted to ask if you guys had any opinions on that, and if your exposure during like a trauma rotation during your surgical intern year was beneficial, especially seeing how VIR, does play a big role in trauma management and bleeds, etc.
Oh, mercy. Did we have trauma experience? So we had to do 3 months of nights. And when you're on nights, you cover, all your services. So I think like surgical oncology, thoracic, whatever. And then you also had to go to every trauma. So that was actually the rotation I started off with in July. And man, that was a bear. But it was wonderful in the sense that like after every trauma, you went to radiology, you went through the images with them, you figured out what was going on quickly. You got to, just see the trauma workup. Towards the end of the year, when things were going fast, if I was on trauma or there was something going on and we have everything covered, I could go scrubbing with IR. It was great. You can go get in those bleeds. You can see what's going on. And if you were clever enough and you got to everything where you worked it up, early, you can kind of control what goes where. So I thought that trauma experience, I mean, it wasn't always the most fun, but it was great once you learned how to do it. And then I had a month of dedicated trauma. And it's just a rough month in terms of like, if you get into one of the warmer months when you're having a ton of traumas, it's tough, but the experience you get from it, just learning how to handle it is great. And they're gonna have these nights on IR, and DR too when you're reading a bunch and you have to deal with, 20 traumas in a night, and half of them are like, hey, it's bleeding spleen, bleeding this, bleeding that. What can you do? So just learning how to manage it, I thought was really, really helpful.
Yeah, I'll second. A month of trauma is definitely, one of the more flashbulb memories of intern year, but reps are really high, from acute resuscitation to then seeing how a lot of those big pelvic bleeds and things like that will go over to the IR department. A couple times I was able to follow them in and see how those going kind of towards the end of a shift. Um, that's pretty cool. And then seeing, sometimes that same patient on trauma will be managed in the SICU who might also be staffed by one of our more senior IR residents. And so you can kind of see the full circle of like, all right, you have the IR intern there at the trauma bay, and then you have the IR fellow in the case, and then you have the other senior IR resident managing them in the SICU. You kind of can see how, you get this from multiple sides and get a little bit more comfortable with managing those acute patients and seeing kind of how different teams will play a role there. Also plays a role when you're, during your diagnostic years, patients are coming in with traumas and you understand what they're looking for and understand, okay, here are the implications of making this call, and understanding, kind of how to communicate certain things at the right time.
Yeah, I don't have too much more to add to that. At Kaiser, we have 2 months of acute care surgery. We're not, a super heavy trauma hospital, so we don't have any crazy, gunshot wounds or motor vehicle accidents. But we do get the bread and butter cases of like SBO, peritonitic, hostile abdomen, things like that. So then I think it's nice on nights where it's just you and your seniors, so you get to scrub into everything, and they actually let you do a lot at night. And then you also get good with your physical exam because you go and see them in the ED. So I think that's another good way to learn your skills. But yeah, not too much to add.
Suturing too. You get to do so much suturing on that rotation of just about everything. And it's fair game. You're in the trauma bay, you're in the OR. And if you ever get to experience trauma on 4th of July, you will never forget it for the rest of your life.
That's a good point. So it seems like we're talking about a lot of skills here too that just go outside of the OR time you get during that year. You're determining like operative candidacy, managing like fluid resuscitation, sepsis. How important are these skills, do you think, for like the VIR physician moving forward? Yeah.
Um, Something that I mentioned to trauma surgeons whoever's talking about it, when they ask, why are we spending time in the SICU? Why are we spending time on trauma surgery? Is it's often thrown around how great it is that IR can take care of patients without anesthesia and can take care of patients that are too sick for anesthesia. But the other side of that coin is that means you can find yourself often in a situation where you have a very sick patient and the only physician in the room is the vascular interventional radiologist. And so understanding management, it doesn't mean that, if a patient keeps spiraling or something like that, you're not going to call for backup. You don't have to play hero ball, but having the understanding of, okay, I understand resuscitation. I understand, the basics of, giving blood products and all of that, I think is, completely underrated in the current landscape, at least to stabilize somebody. Because if you're putting giant bore sheaths and things like that, or you're taking care of patients that, like I said, can't go to surgery, yeah, just understanding your resuscitation, your management skills are crucial.
I think everything you said is wonderful, and I agree with it. I think something you need to learn your intern year, is when you look at a patient, you need to be able to say sick versus not sick. And someone who's sick and you need to get help on it, you need to do something. That's just a skill. If you see someone that's septic, someone that looks like, hey, they need to go to the OR soon. That's just something you're going to have to develop as you go on. And knowing how to get in and manage that earlier, you're only going to help those patients sooner. They need a line, they need a medication, they need blood, they need a tube earlier. I'll never forget one time on rounds, I came in and walked in a patient. It was just like a normal post-chole tube, excuse me, post cholecystectomy. And he came in and his O2 sat was like nothing. He wasn't breathing. And, we had to intubate him that morning. So just going in and recognizing what you have to do and do it quickly. And obviously that's one of the more obvious ones, but just having that skill set from that is going to benefit you greatly and it's going to help your patients out a lot.
Yeah, I also agree with all the points that were said and echo the same thing. You know, to Jonas's point, like usually the sickest people in the hospital are the ones that end up, coming to the vascular interventional radiology department. And in a way, surgery, when they're operating on super sick people, they have the anesthesiologist right there. They have backup. But for us, if something goes wrong, you have to, like, everyone looks at you and you have to know what to do. You can't freeze up. And I think the getting the reps in the ICU, I think is critical to developing that kind of confidence, just learning the algorithms. And then to Dr. Farag's point, knowing when someone is super sick, being on high alert versus, not.
And this question might be geared more towards Dr. Abedira and Dr. Cruz, but how confident do you guys feel after your, surgical intern year? Now you're going to start your, VIR residency. You have diagnostic, heavy years. You have, VIR heavy years. But how confident did that surgical intern year make you feel in terms of going in to what you applied for?
You singled me out there, so I'm gonna have to go and answer it. Uh, I think coming out of there, you really towards the end, you kind of feel like Superman. Like you've done so much and you've been in so many critical situations, and every single case is like IR. In the morning rounds, you go through imaging on every single case, every trauma, you use an ultrasound. So I think you come in as prepared as it gets, and it's almost intimidating to your co-residents just how much ahead of the curve you are, even if you're even in the diagnostic rotations. You've scrolled through a CT for the first time. You've been able to see what's going on. You've seen the acute stuff. So I say in terms of preparation, I think it's super important. You come in leaps and bounds above your cohorts.
I'll say, the reps definitely build confidence. I remember my first one or two night shifts where you're holding all of the pagers and you're like, I was a med student 3 weeks ago where they wanted to double, triple check my note. And now this patient needs to be near coding for me to make a phone call. It's crazy. But going from that to like 3, 4 months later, you wake up to somebody saying, hey, this patient is unstable, and you're, responding, but it doesn't quite jar you the way that it does. And so definitely, if your question is, how confident was, if I would do it again, then yeah, the confidence, I got out what I thought I'd get out of it, for sure. And then the other thing is moving forward, I think it's about how do you maintain those skills, because it's no secret that the years that immediately follow that are significantly less based in present management of patients. And so I think that's where the current challenge is, and where our field is still trying to understand its identity in that regard. And then the other thing when it comes to confidence is always, the humility that comes alongside that with, I do have skills, but that doesn't mean that I'm not going to, one of the biggest things I think I got on my intern year is when to call for help and when to know that I need to fill the boat with other people that know maybe a little bit more or at least can back me up. So.
Yeah, I'd say I agree with most of what Jonas said. Actually, I agree with all of what Jonas said. The I think the reps really help you build your confidence, and like you said, it's not that you're confident in everything. I think what the surgery intern year helps you do is it kind of helps you have a foundation, and then starting second year, I was starting this year, I started taking call once a month. And on call, it's just me holding the pager, and then I either call the attending if I need help. Otherwise, like I'm the one consulting staff, going to see the patient, writing the consult note and everything. And so I think the surgery intern year helps you because it builds a foundation to the point where you're not thinking about things. Like you're not thinking about, you learn how to be efficient, you learn how to put in orders. So like that allows you to have like brain power, for lack of a better word, to like focus on other things that you need to focus on. And so I think the surgery engineer in that way helped me build confidence in that I know how to do kind of like baseline things, and now I can focus on the next level. And I'm sure as a PGY3, you stop thinking about the things you're worrying about as a two, and you start worrying about kind of next level things. So I think the surgery engineer really helps ingrain that, and then it helps you ingrain like efficiency. Yeah, like Jonas also wrote in the chat too. It's even in the OR, it's why it helps you get experience. Like I remember one of the attendees was behind me. They're like, "No, that's an extra step. Do it again." Like even like closing and opening, they're like, "No, that's an extra step. You grabbed the needle in the wrong place." Like it helps you build efficiency, and then when you learn that in the beginning, it really helps you. Honestly, I think for the rest of residency, probably the rest of your career, because you kind of have that mindset, like, okay, how can I be more efficient? So I think that was one of the big things that helped with that too.
Sounds like no regrets, a lot of confidence building, a lot of preparation for the training. But now, Dr. Farag, I'm really going to single you out because you kind of touched on this before at the very beginning that even to this day, you still use a lot of the skills that you gained and, started in that surgical intern year. So what do you think some of those skills are, some of the ones that are most important to you, maybe use on a daily basis, think about often?
So I think, kind of my approach from A to Z, how I see a patient in clinic, how I get them scheduled for the OR, how I set my OR schedule, how I have the staff turn around the rooms in between, how I see patients in between a really busy OR schedule. How do I take, if we do run into a hiccup and a more urgent case comes in and I run to the hospital quick, and how you still keep your practice afloat. Just learning how to triage and get, this is the highest priority. And then the joke I would say is this is priority number 50 million, stuff you don't need to worry about right now. And that's just something you get with the reps. When you do your own practice, I mean, it's you A to Z. You're the one that has to set it up. You're the one that has to get everything scheduled, and you're the one that has to go in there and do the case. And you have to do a damn good job because if you don't, they're not going to come to you anymore. So I think just learning how to you know, tailor your day to what's the most efficient, what gets things done, and what's get the best results. Um, I truly learned all that my intern year. They beat it into me, they got it in, and we to this day, it's like you guys were saying earlier, it's in the back of your mind. You don't have to think about it now. It's just you just do it because you've had those reps and your brain just thinks that way.
Definitely. And just to the audience really quick, soon we'll be wrapping up here and we'll have like opportunity for a Q&A session. So if you have questions that I didn't necessarily ask, but you're thinking about, feel free to drop them in the chat or use the Q&A function and we'll try and see if we can get some of those answered. And before that, the last thing that I sort of wanted to pose to our excellent panel here is after all these good things that you've said, a lot of the skills that you've discussed about, and that really do apply to VIR as a field, even into attending hood. There's still going to be people who are on the fence. They see a TY year, they're thinking about it, they're thinking about applying to those first and using the surgery years as a backup, maybe. Maybe their program doesn't require it. So, what would you say to the people who are still on the fence? Any last, words, things that maybe would benefit them?
Don't do it. Don't rob yourself to rob yourself. This is your freest year of your career. This is the one year you can go in and learn for free, and just about anything you do is okay. You're there to learn, you're there to get better. That's the one year that you can level up quickly and you can have a good time doing it. And it's the only year you're going to see that much variety outside of radiology, outside of IR. I know a lot of people who did TY and they had a great time by the beach and they knew how to treat hypertension and diabetes, and that's about it. And I promise you that's not going to help you in IR. IR is not easy. If you want to wait till, PGY 2, 3, 4 to get, test your metal, you are not going to have a good time. Go ahead and get that going now, and it's going to make the rest of your career so much easier.
Yeah, I mean, no matter what you pick, it's still intern year. And even your easier one, it's not like I think I had one friend who one of his TYs, he had like 4 months of research among some other things. But it still was like a whole year that you're spending at this hospital. And I thought at the end, I think he did like 2 months of neonatal medicine and 4 months of research. And at the end of it, after spending a whole year in the hospital as an intern, you think about, all right, what skills did you walk away with? And, you know, Dr. Farag's on the money here. I just, what is going to give you the best skills down the road? Whatever you do is paying dividends down the road. So what foundation are you starting with? And you can definitely go the route of the TY year, but I know that month for month, the highest yield option was for sure surgery.
Yeah, I also agree with that too. Don't rob yourself of, an amazing year. And then, I had just a couple of friends who also did TY years, but TY year, you're going through your rotations. No one in the department really has any reason to teach you. I mean, that sounds kind of harsh, but it's true. Like you're gone in a month, they can probably ignore you for most of the time and or not let you try any procedure or not do anything, and they really have nothing really to gain from that. Whereas surgery, you're there for the whole year, you're part of the team. For me, I made lifelong friends. I'm still like best friends with most of my co-interns. You guys go through all that stuff together, and you like build a great foundation that's already going to kind of put you ahead of, someone who may not have done that to actually be, take strides towards being a good VR attending. So I think there's a lot of points, there's a lot of reasons why I think you should do a surgery intern year. And so, um, don't cheat yourself, I'd say. Same as Dr. Farag.
All right, thank you. Those are all of my questions. We do have some questions in the chat. One thing that we did touch on just a little bit is where you do your surgery intern year. And is there maybe a general pattern you've noticed about doing one at, for example, like a county hospital versus like a large academic center? Is there like a general rule about that? Is there likely you're going to get a different experience depending on which type of hospital you do your surgical intern year at?
I mean, I think anywhere you go, you're gonna, get the surgical experience. Oh, mercy. But skip to me. But if you I think getting those, those I guess what do you call them, the smaller hospitals thing. Like technically mine's a county hospital, and I feel like I got to do more because of that. But I had friends that, at my residency program that they came in and they were able to do a lot. But I do think the smaller programs let you do a little bit more. And you guys can tell me, your experience too. But in terms of getting to have the run of the mill and feeling like, you had more ownership, I can't say anything because I didn't do what you guys did, but I felt like I got to do a very, very decent amount.
Yeah, reach out to the people at the programs that you're considering. Ask what the reps are. Um, Different academic centers may operate completely differently in terms of their experience, just based on their culture. But your smaller programs, like you said, are going to be a little bit more, maybe a little more hands-on. There's a little bit less red tape in terms of like hierarchy and things like that. But yeah, I just reach out.
When you guys get to be my level, your wife shoots off a warning shot like, "Hey, man, playtime's almost."
Yeah, I'd agree. It's I would say Kaiser is probably a smaller program. There are no like fellows can't box you out because there are no fellows here. So, but then again, you can go to a bigger program where the fellows and seniors like to include the interns and they like to teach and they want everyone in the OR. So I think to the points of everyone else, it's a lot to do with culture. So I think just reach out, like Jonas said, reach out to people and see what their experiences were. Most people will be honest with you.
Sure. And we have a question here about any specific resources that you used for the surgical intern year specifically to sort of help give you that knowledge base and skills you need.
I don't think I touched a book my intern year. I mean, it was just all day, every day. Those attendings are gonna grill you on certain things, and I just kind of learned from that. But I'm sure there's a book, and if you learn that way, I'm sure that's the way to do it. But that's just not how I had had anything to do with intern year. It was all on the ground learning.
I'd say there's like kind of two major textbooks. There's like Sabiston's and then Schwartz is the author of like the two kind of Grail books. They're super dense. Even like the categorical intern didn't really touch that. There's a in-service exam called ABSITE that we took in January, and that's kind of like to kind of test your knowledge of halfway through the year. That one has these review books that are really good. And then there's I'm a podcast person that I like listening to things while I'm at the gym. There's a podcast called Behind the Knife that I'd highly recommend. I even listen to some of the episodes now, but it's like a super quick review. And then other than that, yeah, really it was just like hands-on learning, just asking questions and being present during the rotations.
Didn't touch a book.
A B asked in the chat if there's any advice on scheduling step 3 during surgery intern year.
Do it whenever.
Yeah.
Whatever's easiest. Do not overthink this. It is 100%. I think the pass rate is above 97%. For you to be here, don't do that to yourself. Like it is such an afterthought, I promise. You'll be fine.
So a lot of people could do it during their elective year. I was so ingrained in my surgery year that I was like, you know what, I just kept pushing it off. And then next thing you know, I was actually at PGY 5 when I took step 3. Um, I don't know anyone else that did it that way. I don't recommend doing it that way. Just get it over with. I studied like a day and a half, and I wouldn't recommend that to everybody, but you'll get through it and just study for it, do the Q bank, and be done with it. First chance you get. Um, it's never, everyone says it's easier. I didn't think it's particularly easier at that point, but we got through it, so just get it over with.
Yeah. Or
Yeah.
don't do the Q bank, honestly.
Yeah.
I promise it is so
As a
low
PGY
stakes compared
5,
to
if you do it right at intern year, I'd agree with you. Knock it out. Don't
yeah.
wait. Don't wait.
Compared to, I know it has the name STEP, but like compared to the other ones, you'll be fine. I will say that I have heard of one person. He was a general surgery resident thinking about you, Dr. Frog, doing his PGY 5. Apparently, there's a 7-year limit. It's probably why you did it PGY 5. There's like a 7-year bookend from like either step 1 or step 2 through completing step 3. And if you don't get it done in that time, I think you have to do 1, 2, and 3 all over again. There's something like that. But short of pushing it all the way back, just whenever's convenient.
Yeah, the look on your program director's face when you tell him like, "Hey man, I still got to do this," is almost priceless.
Yeah, I'd say same as Jonas. I mean, I took level 3, but it's pretty much the same thing. Just to get it over with. I think I looked at the case. There's like a case thing that you like just learn the format of it because you can kind of screw up otherwise if you can get points lost if it's not even medical based. It's like if you click the wrong thing, you can get a point off for it or write the wrong thing. Other than that, I'd say just take it and get it over with.
Melanie asks a plausible question where, if your prelim program at the institution that you are going to be going to for IR, maybe if it's not as, good as we are talking about in terms of getting, IR residents involved, prelims involved, would it be better to go to that program because it's at the institution you're going to be going to, or would it be better to maybe just do a different program altogether? for that year?
That's a choice you'll have to make. Are you married? Do you want to, travel? Do you have kids? What is kind of like your ultimate goal? I think I moved like four times in 4 years at one point, and it was just not fun. But I will say, if you can go to a place that's going to give you a good experience, I wouldn't hesitate to do it for a second. Yeah, it sucks, traveling for a day or two. But the experience you're going to get from it outweighs any inconvenience you're going to have. It's always nice to stay at the same program and know the same people if the program is, sufficient. But if it's not, I would go for it and go for the best option. I mean, you're only benefiting your career being at a better place.
Yeah, I'd agree with what Dr. Brock said. It's nice, if you happen to be at a place that also has a good surgery intern year, because that way you'll get to learn everyone you'll be working with, and you'll be familiar with the hospital. You don't have to move, all those things. But if it's not good, I would prioritize the culture, prioritize the place that's going to give you a good experience for a year. They'll get you to the OR, all the things that we talked about. I think that should be the priority more so than anything else.
And if you're really stuck on programs, there are certain programs that take for their prelim year almost exclusively IR bound residents. They know the game for the most part. They understand what you're looking for. They know how to plug you in. There's a number of those out there. So you can, if you're ever on the fence, just see what kind of prelims do they usually take and what were those experiences like.
There was a study done once, and the IR prelim was favored among just about any other prelim out there. That was a really, really awesome study that just showed, the program directors also see your value. Like, we love to have these guys here. They're here to work and they know what they're doing and they keep their head down and get things done. So,
And one last question here. Thoughts on academic programs that have more APP support versus, for example, county program that may not have that support?
I mean, my program had on certain rotations APPs, and I thought they were very helpful. There's so much work to do that having somebody help you with that work, and you'll learn a lot from them too. Some of these have been in the game for like 20 years, and they know what they're talking about. So I don't think it's a matter of like them stealing your reps or anything like that. I think you learn to play as a team, and you kind of see where everyone roles fits in. So I had no issues with APPs. I thought they were very beneficial, and I really enjoyed working with them.
Yeah, I think support's always helpful. You're going to be busy. I think it's hard to gauge how much the presence of APPs will affect your actual workload, because it's going to depend on what the actual patient workload is. Um, I think we have APPs for probably like half of our rotations, but some of my hardest rotations have been the rotations where we had APPs there, just because they're there to support a certain amount of volume or complexity. So hard to gauge, I think.
Yeah, for our program, the APPs in surgery, they really only help on the clinical side or kind of like help with admin stuff. So they've been amazing. They basically just kind of free you up to do more OR time, more surgeries and things. So they were great here.
Well, thank you, everybody. Thank you to our panelists for volunteering during your busy schedules to be here for this event tonight. And thank you, everybody, for coming.